Hi guys, it's me, Professor D. Welcome back to my YouTube channel. On this video, I'm doing another Kahoot, and we're going to be covering care of the patient with Addison's disease. Now, before we get started, as always, I'm going to ask you to please support me and support this channel by liking this video. You're going to love it, so go ahead and give it that thumbs up button now. Subscribe to my channel if you haven't done so already. And don't forget, I'm now offering next generation NCLEX review sessions. It's a two-part sessions, part 1, part 2. And you can also sign up for private tutoring. If you're currently in the program, you're not studying for boards, but you're just trying to get through the nursing program, I have something for you. Check out the audio lessons I have available on my website, nexusnursinginstitute.com. Almost daily, you can find me covering a variety of nursing topics across my social media platforms, such as TikTok, Instagram, and Facebook. Oh, that's my phone. Don't worry about that. My handle's the same everywhere, Nexus Nursing. So without any further ado, guys, let's get started. Addison's disease. First question. You teach your patient with Addison's that they may need an increased dosage of glucocorticoids in which situation? Would it be if they were graduating school? Would it be if they were gaining weight? Would it be if they were getting married? Or would it be if they were having a wisdom tooth pulled? When would you teach your patient with Addison's disease that they may need an increased dosage of glucocorticoids? Okay, wow. Most of you guys chose gaining weight, but the correct answer is having a wisdom tooth pulled. So any stressful event, guys, such as a surgery, such as pregnancy, such as illness, such as trauma, the patient most likely is going to need an increased dosage, because I want you to think about it. If you take both of your hands, right, you put them behind your back, where your palms are sitting, that's around where your kidneys are. Right on top of your kidneys are your adrenal glands. Your adrenal glands are responsible for cortisol, for aldosterone, for epinephrine, for glucocorticoids, your fight or flight hormones, right? So anytime the patient is going to be confronted with a very stressful situation, if they have Addison's disease where they're lacking cortisol, they're lacking aldosterone, they don't have those stress hormones, guess what? They're going to need more of an exogenous source, more of an outside source. So you're going to teach that patient any stressful situation, having their wisdom tooth pulled, having surgery, if they get pregnant, if there's any trauma to their body, they may need an increased dosage. So they're going to have to let the healthcare provider know, okay? Because that's what Addison's is. When you hear Addison's disease, I want you to think you need to add salt, add sex, add sugar. You need to add salt. What is salt? Those are your mineral corticoids. The patient doesn't have enough of those. The patient doesn't have enough what? Sodium, right? What follows sodium? Fluid. So the patient has Addison's disease and they don't have enough sodium, and we know fluid follows sodium. Guess what? What do you think is going to be happening to that patient's body? Do you think they're going to be full of fluid or not have enough? Not have enough. They're going to be in fluid deficit. We're going to be worried about that patient being hypotensive, right? That patient's going to be skinny, not big, not gaining weight, right? So not enough salt, not enough sex. What do I mean by not enough sex? Those androgen, those sex hormones, and not enough sugar. What is sugar? Glucose, those glucocorticoids. So when you think of Addison's disease, think that you need to add salt, add sex, add sugar. How you guys doing on the live? Very good. All right, which should be your priority for a patient in Addisonian crisis? Is it to prevent hypertension? Is it to prevent irreversible shock? Is it to prevent infection? Or is it to prevent depression? Someone on the live said, what days do you do NCLEX reviews? They're on Mondays. Very good. Most of you guys chose the correct answer, to prevent irreversible shock. Again, think about the pathophysiology. Patient with Addison's disease, you need to add salt, add sex, add sugar, because they don't have enough of it. So think about it. That patient with Addison's disease, they don't have enough salt, which means they don't have enough fluid, which means the blood pressure is going to be what? Down, low. It could be low to the point that this patient can go into shock where those organs actually start to shut down because there's not enough perfusion happening. So whenever you think about a priority, always think about what can kill your patient the fastest. Look at our choices. Preventing hypertension. Well, the patient with Addison's disease, if anything, they're going to have hypotension and not hypertension. So that couldn't be the answer. Preventing infection between that patient getting an infection and irreversible shock. What's going to kill them fastest? Irreversible shock. Now, them getting an infection, that can cause them to need more of the glucocorticoids, more of the steroids. However, a priority is going to be irreversible shock. And of course, preventing depression. We never want our patient to have depression, but guess what? That's not going to kill you as fast as irreversible shock. And any patient that's in Addisonian crisis is at increased risk for shock. Whenever you see a disease process, such as Addison's, and there's crisis behind it, whenever you see that, just think of that disease process times 100. So think of what happens with the patient who has Addison's disease times 100, and that's your crisis, okay? Which is an expected clinical manifestation of adrenal crisis? Would it be fluid overload? Would it be pain? Would it be peripheral edema? Or would it be hunger? Very good. You guys got it right on the live. I see a lot of right answers. Let's see. Wow, most of you guys chose hunger, and pain is the correct answer. So let's talk about this. Not having enough of these adrenal hormones can cause pain. The patient can have headache, they can have abdominal pain, they can even have back pain. Okay, lacking those adrenal hormones will cause pain. Now let's look at the wrong answers. How did 13 of you guys choose fluid overload? When I just told you a patient that has Addison's disease, you need to add salt, add sex, add sugar. If they don't have salt, you want to know what else they don't have? Fluids. Fluids follow salt. I want you to think about this. If fluids follow salt and they don't have enough salt, and we know they don't have enough salt because we're talking about Addison's disease, how are they going to have fluid overload? Make it make sense for me. It doesn't make sense, right? If anything, that patient's going to be in fluid deficit, not overload. Next choice, peripheral edema. Well, you'd have peripheral edema if you were in fluid overload, but the patient with Addison's is going to be the opposite. They're going to have fluid deficit, so we're not going to see peripheral edema. And hunger, no, that patient's going to have anorexia. They're going to have decreased appetite, not hunger. What we will see in the patient that has Addison's disease, especially if they're in Addisonian crisis, is pain. Again, headache, back pain, abdominal pain, okay? All right, select all that applies. Your patient with Addison's disease is taking replacement corticosteroids. What side effects would you teach the patient about? Select all that apply. How do we treat select all that apply? As true or false. So we're looking for side effects of the corticosteroids. Here's our choices. Hyperkalemia, muscle weakness, mood changes, hypocalcemia, increased risk of infection, hypotension. Select all that applies. Okay, so let's talk about this. The patient's taking corticosteroids. We're not talking about Addison's disease. We're talking about the actual medication. What would be side effects of those medications? The correct answer is going to be muscle weakness. And let's talk about this muscle weakness. Muscle weakness, this happens because when the patient's taking the medication, sodium's reabsorbed. Remember, in Addison's, patient doesn't have enough sodium. So they're getting the corticosteroids so the sodium can be increased. Okay, wonderful. That sodium's increased. What happens is protein breakdown happens and it causes muscle weakness. Okay, so with the corticosteroids, we expect to see muscle weakness. That's a side effect. What else? Mood changes. When it comes to these steroids, you will see mood changes such as confusion, such as lethargy, such as irritability, such as depression, such as psychosis. Absolutely mood changes. Hypocalcemia. Let me tell you why. When it comes to corticosteroids, they have an vitamin D action, I should say. The exact chemistry of it, I don't know. I never bothered to look it up. But what I do know is that you need vitamin D to absorb calcium. So if corticosteroids work against vitamin D, that means it's working against calcium because you need the vitamin D for calcium to be absorbed. So that's why it causes hypocalcemia. Again, what is the chemistry behind it? No clue, but I know it works against vitamin D, and anything that's going to work against vitamin D is going to work against the absorption of calcium. And last, increased risk for infection. Absolutely. When it comes to steroids, four things you guys got to know. I'll tell you this right now. When it comes to steroids, no matter what type of steroid we're talking about, one, you're going to be worried about infection because steroids increase the risk of infection and mask the signs and symptoms of infection. Two, you're going to be concerned about glucose. Steroids are very sugary. They can cause hyperglycemia. It can turn a patient diabetic. Three, steroids make the bones porous. It can cause osteoporosis, so safety is a big issue. And four, steroids are very hard on the stomach and cause the patient to have, gastric ulcers. So that's why you never give steroids on an empty stomach. The patient has to eat before they take steroids. So absolutely increased risk of infection. Now let's talk about the wrong answer choices. Look at hyperkalemia. I want you to think about it. Guys, you have to think about the pathophysiology. What's happening for it to make sense? Patient, one second, guys. My daughter just came in and gave me a note. My tooth hurts really bad. And so what are you asking me, honey? Yes, baby. Are you leaving now?
I told her to hold up on
Okay. I love you. Come say hi. You're already here. Hi. All right. Anyway, guys. Bye. I love you, baby. So let's talk about this. So patient has Addison's disease. And we know in Addison's disease, they don't have enough salt. They don't have enough sex. They don't have enough sugar, right? We're giving them medication for it. We're giving them corticosteroids. We expect the salt to be what? Increased, because the corticosteroids will cause an increase in the reabsorption of sodium. Well, guess what? Sodium and potassium has an inverse relationship. So when sodium goes up, guess what happens to potassium? Potassium goes down. So when that patient's getting corticosteroids, if anything, we're going to expect to see hypokalemia, not hyper, because sodium and potassium have an inverse relationship. So that's why that's not the answer. And let's talk about hypotension. Patients got Addison's disease. They don't have enough salt, sex, sugar. We're giving them corticosteroids. We expect that to increase. Increased salt brings what? Increased fluids. Increased fluids brings what? Increased blood pressure. Because remember, blood pressure, all blood pressure is a force that's being exerted against vessel walls. So more fluid, more pressure. So with this medication, we expect to see the blood pressure go up, not down. That's why hypotension is not an answer. So when it comes to corticosteroids, side effects we're going to be concerned about is going to be muscle weakness, it's going to be mood changes, it's going to be hypocalcemia, and it's going to be increased risk for infection. Are you guys still following me on the live? I'm not going too fast? All right, let's keep going. Your patient's receiving dextrose and normal saline. You note that the arm, what is that saying? You note that the arm that the line is in is swollen and hard. What's going to be your first action? So the patient's getting IV fluids, and that line that the IV is infusing in is swollen and hard. What are you going to do first? Are you going to DC the infusion? Are you going to apply warm compress to the site? Are you going to slow down the infusion, or are you going to administer potassium IV push? Okay, very good. You're going to DC the infusion because you suspect what? Infiltration. Why else would that arm be hard and swollen? Why? All of that fluid has infiltrated. It's now in the tissue. Okay. So whenever something is affecting your patient, the first thing you're going to do is stop whatever's hurting your patient. You're going to discontinue that line. Next, look at apply warm compress. So you're trying to tell me you suspect infiltration and you're going to apply heat to make it spread even further. Does that make any sense? Next one says slow the infusion. All that means is you're saying you're going to kill your patient slower. You're going to harm them at a slower rate. No, you don't want to slow the line. You want to disconnect it, DC it. And I'm happy nobody chose give potassium IV push. We are not, what do you call the people when someone is on death row and the person who actually gives the infusion of the potassium to kill them? What do you call them? I don't know, but you guys know what I'm talking about. The person who actually gives the potassium chloride to the inmate that's on death row, you're not them. So you're never gonna administer potassium IV push. Okay. Executor. Thank you. You're not the executor. All right. Next question. You're encouraging your patient to increase fluid intake. Which fluids would be most appropriate? You want your patient to increase fluid intake. What are you going to teach them to take? Is it fat-free ice cream and diet soda? Would it be water and tea? Would it be chicken broth and juice? Or would it be coffee and red wine? What are you going to encourage your patient to increase in their system if they need to increase fluid intake? Wow, 29 of you guys chose water and tea. So let's talk about the right answer, then we'll go over the wrong answer choices. The correct answer choice is chicken broth and juice. Why? Again, it all goes back to the pathophysiology. Let's think about what's happening in Addison's disease. We need to add salt, add sex, add sugar. They don't have enough of it, right? So we're going to encourage them to drink fluids high in sodium and glucose. Chicken broth is high in what? Sodium. Juice is high in what? Glucose. Duh. Let's look at the wrong answer choices. I'm happy no one chose fat-free ice cream and diet soda. We don't want diet anything because if it's diet, there's no glucose. This patient needs glucose. The glucose is too low, right? So we're not going to choose that. 29 of you guys chose water and tea. Let's think critically through this, right? I have nothing against water. Nothing against water. But remember, I teach this to you guys all the time. If the entire answer is not correct, the entire answer is what? Incorrect. What's the problem with tea? Tea has what in it? Caffeine. What's the problem with caffeine? Caffeine's a diuretic. Think about it. The patient that has Addison's disease, their sodium is low, which means the fluids are low. Do you think them having a diuretic would be a good choice? Absolutely not. We're trying to get them to increase fluids, not decrease fluids. Remember, guys, caffeine irritates the bladder. It makes the patient want to urinate more. We're trying to make the patient hold on to fluids. So why would we tell them to drink coffee or tea? Absolutely not. And I'm happy no one chose coffee and red wine because we're not going to encourage alcohol. And again, we're not going to encourage anything that has caffeine or anything that can act as a diuretic. We're trying to get the patient to hold on to fluids. Next question. The patient with Addison's disease should be assessed for what? Would it be weight gain, hunger, lethargy, or muscle spasms? Two of you guys chose muscle spasms, and that's incorrect. That patient with Addison's disease, we expect to see what? Muscle weakness. Okay. Correct answer is lethargy. That patient that has Addison's disease, sodium's low, fluids low, we expect to see um, neural changes, such as lethargy, such as confusion. Okay. Not weight gain. You know, that patient's going to be very skinny. They're going to be losing weight. They have poor appetite. So definitely not weight gain and definitely not hunger. Those CNS changes in the patient with Addison's, definitely lethargy and those other CNS changes that I explained. All right, your patient has Addison's disease. Which outcome would be a priority? Would it be compliance with the medication regimen? Would it be avoiding normal activities with stress? Would it be maintaining a 2-gram sodium diet? Or would it be preventing hypertensive episodes? What do you guys think? I'm so happy I decided to do this Kahoot because these answers you guys are giving me on the live, it's crazy. What's going on? All right, correct answer is compliance with medication regimen. The patient that has Addison's disease, the adrenal glands are not working properly. They are not secreting the correct amount of hormones necessary for them to survive. Okay, so they have to get an exogenous source. So it's very important that they are compliant with their medication regimen, and that includes if they're going to have a stressful situation, such as a surgery, such as a trauma, such as pregnancy, such as getting something pulled, that they let the healthcare provider know so that the dosage can be increased. Now, I noticed 9 of you guys chose avoiding what type of activities with stress? Normal. I know you guys saw stress and you jumped on it, but you guys got to be careful because let me tell you something. This is exactly how NCLEX tricks you as well. Okay, look what it says: normal activities with stress. Guess what? You cannot live a stress-free life, right? So that's not going to be the answer because you're going to have stress. But the problem is if you're coming across something extremely stressful, such as, you know, other examples that I just mentioned, then you know you're going to let the healthcare provider know because you expect your dosage to be increased. But you're not going to teach them to avoid normal activities with stress. If that patient has Addison's disease and they're a student, you're going to tell them to drop out because guess what? Every quiz is going to be stressful. Every exam is going to be stressful. If that person's engaged to get married, are you going to tell them to drop the fiance? Because guess what? There are going to be times in the marriage where you're going to be stressed. You're going to be stressed planning for the wedding. So this word normal, that is what should have clued you in to say, I'm not going to teach them to avoid normal activities with stress. Next, 9 of you guys chose maintaining a 2-gram sodium diet. A 2-gram sodium diet is a low sodium diet. Again, let's go back to the pathophysiology. This patient has Addison's disease. We need to add what? Salt. Why would we put them on a low sodium diet? Does that make any sense? Absolutely not. They're already at risk to be hyponatremic, hypotensive. Why would we put them on a low sodium diet? That makes no sense. That's why we shouldn't choose it. That's why we shouldn't have chosen it. Last, preventing hypertensive episodes. Nope. That person with Addison's disease, if anything, they're going to have hypotensive episodes. So the only correct answer here, guys, is medication compliance. All right, what causes the eternal tan in the patient with Addison's disease? And I got a picture of JFK here because he's famously was known to have Addison's disease. You know, that eternal tan, that tan that he just always had. What causes the eternal tan? Is it photosensitivity, increased bilirubin level, adverse effects of glucocorticoids, or elevated secretion of ACTH? ACTH is adrenal corticotropic hormone. What causes the eternal tan? All right, so 15 of you chose increase a bilirubin level. No, right? If it increased bilirubin level, this patient will be looking more jaundice instead of tan. So that's incorrect. The correct answer is elevated secretion of ACTH, which is adrenal corticotropic hormones. Now, one of the things that ACTH does, it increases melanocyte production. Melanocyte Melanin, yeah. So with that increased melanin, it gives that darker complexion. It gives that eternal tan look. All right, last question. When should the patient with Addison's disease expect the need for increased glucocorticoid therapy? Would it be when returning to work after a vacation? Would it be when going on a vacation? Would it be when having surgery? Or would it be when having a physical? Someone said they have a final on Monday. They're so happy they joined this live. I'm happy you did too. Very good. When having surgery. Again, guys, major illness, trauma, dental work, pregnancy, anything that is traumatic to the body that will cause a huge stress on the body that would make the adrenal glands want to secrete glucocorticoids, but it's unable to, that patient's going to need a higher dose of an exogenous source, an outside source. So very good. I'm very proud of you guys. So let's see how you did.